Welcome to the Deep Dive. We tackle complex subjects, cut through the noise, and give you the essential insights. Today, we're plunging into a really tough challenge in equine health. Clostridium difficile infection in horses, C. diff, as it's often called. We've really gone through a lot of material here, scientific papers, research notes, to give you a clear picture of this condition, without making it too overwhelming. Our mission today is to explore C. diff in horses. We'll look at how they get it, what signs to watch for, how vets figure it out, and the pretty intensive treatment involved, something that needs fast action, and hopefully by the end of this you'll really understand why.
Absolutely. And it's not just about naming the bug, is it? It's about understanding this whole complex interaction happening inside the horse. What's really interesting here isn't just the symptoms, but the sheer impact it has and how much nuance is needed. Understanding why it happens is just as vital as knowing what it is. It really highlights the delicate balance in a horse's gut.
Okay, so let's start right there. What exactly is Clostridium difficile infection in horses? Why is it such a big deal?
Well, fundamentally, C. diff infection, or CDI, it's a severe inflammation of the horse's gut. We're talking the small intestine, the cecum, the large colon. What makes it so dangerous, really, are the powerful toxins the bacteria can produce. This leads to varying levels of systemic poisoning or toxemia. The bacterium itself, C. difficile, it's gram-positive and forms spores. That basically means it's a hardy little organism. It can create these protective shells, the spores, to survive really tough conditions.
Sores, right. So they can hang around.
Exactly. And here's a really key point. C. diff can actually live in the gut of some perfectly healthy horses, especially a fair number of young, healthy foals, without causing any trouble at all. The disease, the actual illness, only kicks off when these bacteria start churning out potent toxins. Think of them like tiny weapons. There are two major ones. Toxin A, that's an enterotoxin. It targets the gut lining, makes it leaky, causes a lot of fluid loss.
Okay.
And toxin B, that's a cytotoxin. It's even nastier. It directly kills the cells lining the intestine. And what's really concerning is that strains producing only toxin B can still cause severe disease. It shows how potent toxin B is on its own. So these toxins, they damage the lining, cause fluid to pour out, cause mucosal damage, inflammation, the works. There's also something called a binary toxin some strains make, but honestly, its role in horses isn't really clear yet. But the core issue, the mechanism, it boils down to a disruption. The normal, healthy gut bacteria get thrown off balance, and that gives these toxigenic C. diff strains the chance to multiply and take over.
That makes sense. Like the ecosystem inside gets disrupted. So, okay, how do horses actually get this? What puts them most at risk? Let's unpack that.
Right. The single biggest risk factor, and this is so important to understand, is antimicrobial use, antibiotics.
Really? The drug's meant to help.
Exactly. It sounds counterintuitive, doesn't it? But broad-spectrum antibiotics, while treating one infection, can unfortunately wipe out the beneficial gut bacteria. They remove the natural guards keeping C. diff in check. So it's like opening the door. It explains how treating one thing can accidentally trigger this other, very serious condition. We see it commonly linked to beta-lactams, things like penicillin, ampicillin, cephalosporins like ceftiofur, also macrolides, erythromycin, azithromycin, trimethoprim sulfonamides, clindamycin, rifampicin, even gentamicin can be implicated sometimes.
That's quite a list.
It is. And here's a specific kind of interesting detail. Think about mares whose foals are on macrolides, maybe erythromycin for rhodococcus equine pneumonia, a common foal issue.
Okay.
Those mares are actually at higher risk themselves. They can ingest leftover antibiotics from the foal's manure, just through grooming or contact, and that can disrupt their gut flora.
Wow, that's a subtle way it can happen.
It really is. Shows how interconnected things are in a barn environment.
So antibiotics are number one. What else makes a horse vulnerable?
Well, hospitalization is a big one. Stress, too. Horses in vet clinics can be exposed to C. diff spores shed by other animals. And just the stress of being sick, transport, changes in their routine, changes in diet, all that can really impact gut health and make them more susceptible.
So stress is a factor. What about diet changes?
Yeah, sudden or drastic dietary changes can definitely alter the gut microbes. Anorexia or simply not eating enough, that disrupts the gut too. Gastrointestinal surgery is another risk factor. And of course, any concurrent illness that just generally weakens the horse or compromises their gut integrity, it all plays a role.
Does age matter? Are foals more at risk than adults?
Age is definitely a factor. Newborn foals are especially susceptible. Their gut microbiome is still developing. It's not fully established yet. So interestingly, they can sometimes get CDI even if they haven't had any antibiotics. Just shows how vulnerable they are early on.
Right.
In adult horses, while you can find C. diff in healthy ones, clinical disease is much more often tied to those predisposing factors we talked about, especially antibiotic use.
And the spores you mentioned, they're in the environment.
Absolutely. Environmental contamination is key. C. diff forms these incredibly tough spores. They can survive for ages in soil, in feces, on surfaces, in hospitals or barns. They're like microscopic fortresses, really resistant, which makes transmission, an ongoing challenge.
Okay, so these tough spores are out there. If a horse encounters them and the conditions are right, say after antibiotics, what does the infection actually look like? What are the signs? You said it can mimic other things.
That's the tricky part. The clinical signs often look exactly like other causes of acute colitis, severe diarrhea, things like salmonella or C. perfringens infection. And the severity, it can vary hugely, from quite mild to incredibly severe and life-threatening. The absolute core sign is diarrhea. It can be profuse, watery, maybe semi-formed. Often it contains mucus or even blood, giving it a hemorrhagic look. And it frequently has a really foul odor.
Okay, foul-smelling diarrhea.
Yep.
What else?
Colic. Abdominal pain is very common. Again, it can range from just mild discomfort, looking a bit unsettled, to really severe violent colic. Fever is typical. But in very severe cases, if the horse is going into shock, their temperature can actually drop below normal. That's a bad sign.
Subnormal temperature. Right.
Yeah. And then you get the more general signs of severe illness, lethargy, depression, just looking really dull, anorexia, not wanting to eat, and crucially, dehydration. They lose massive amounts of fluid and electrolytes through the diarrhea.
It's amazing how a gut problem can cause such systemic chaos.
Yeah.
Can you explain that link? How does gut damage affect the whole horse?
It's a direct cascade. The damage to the gut lining allows toxins and bacterial components like endotoxin to leak into the bloodstream. This triggers widespread inflammation and shock, what we call toxemia or endotoxemia.
Right.
So you start seeing signs of shock. The heart rate shoots up, that's tachycardia. Breathing becomes fast and shallow to dyspnea. If you look at their gums, the mucous membranes, they might look congested, bright red, almost injected, or even a sort of brick red color. Capillary refill time, when you press on the gum and see how quickly the color returns, it becomes prolonged, sluggish. And the pulses you feel, say, at the jaw or leg, they feel weak.
And then the really scary complications start.
Yes. That's when you can see things like ventral edema, swelling under the belly, in the sheath area, or down the legs. This happens because so much protein leaks out from the damaged gut into the intestines. The blood protein levels plummet, hypoproteinemia, and fluid leaks out of the blood vessels into the tissues.
Right. The protein loss causes swelling.
Exactly. And then there's laminitis. A huge concern. This incredibly painful hoof condition is often triggered by the endotoxemia circulating in the blood. It's a common and devastating complication.
Laminitis is always serious.
Always. In the worst cases, horses might become recumbent, just unable to stand. And sadly, sudden death can happen, especially in very ratted, peracute cases, sometimes even before significant diarrhea develops.
Wow. Does it look different depending on the horse's age? You mentioned foals are different.
Yes, there's a noticeable pattern based on age in terms of where the lesions, the damage occurs. In very young foals, say less than a month old, the small intestine is pretty much always involved. The colon and cecum might be affected too, or they might not. Hemorrhagic enteritis, bloody inflammation of the small intestine, is really common in these little ones.
Okay, small intestine in foals.
Right. But in older foals and adult horses, the damage is typically concentrated in the large intestine, the colon, and sometimes the cecum. It rarely affects the small intestine in adults.
Got it. So with all these overlapping signs, how do vets actually pinpoint C. diff? Is there anything unique clinically?
That's the million-dollar question, isn't it? Because clinically, no, there isn't usually one single sign that screams C. diff versus, say, salmonella. So a definitive diagnosis really hangs on detecting the toxins produced by C. difficile in the horse's feces, combined with those compatible clinical signs. The first steps are always strong clinical suspicion. History is key. Has the horse had antibiotics recently? Been hospitalized? Under stress? And do the signs, the acute diarrhea, colic, fever, fit the picture of colitis?
So history plus signs point towards it. Then the lab work.
A CBC, the complete blood count, often shows characteristic changes in white blood cells. You might see neutropenia, a low count of neutrophils, often with immature forms called a left shift, and toxic changes, especially early on. Or sometimes a very high white cell count. The packed cell volume, or PCV, is usually elevated, showing hemoconcentration from the dehydration. Total protein levels can be variable, sometimes masked by dehydration initially.
Okay, and the blood chemistry, what does that show?
The serum biochemistry panel is critical. We're looking for key indicators of gut damage and systemic effects. A big one is hypoproteinemia and hypoalbuminemia, low total protein and low albumin. That reflects that protein-losing enteropathy, the protein leaking from the gut. Although, again, severe dehydration can sometimes artificially bump these up initially.
Right, hides the loss.
Yeah. We also see major electrolyte imbalances, low sodium, low potassium, low chloride. Metabolic acidosis is common. Elevated lactate levels are a worrying sign, indicating poor tissue perfusion, essentially shock. And often, elevated BUN and creatinine, which points towards dehydration affecting kidney function, what we call pre-renal azotemia.
Okay, so the blood work paints a picture of severe illness and gut damage. What's the next step for actually confirming C. diff is the culprit? What are the go-to tests?
The most reliable way to diagnose active CDI is testing the feces specifically for the C. diff toxins. That's the gold standard, diagnostically speaking.
Wow.
The most common rapid test is an ELISA enzyme-linked immunosorbent assay. This test detects the presence of toxin A and toxin B directly in the fecal sample. Quick, relatively inexpensive.
ELISA for toxins. Okay.
Then there's PCR polymerase chain reaction. PCR detects the genes that code for toxin A and toxin B. It's actually more sensitive than ELISA.
More sensitive sounds better.
It is more sensitive, but there's a catch. A positive PCR result just tells you the horse has C. diff bacteria carrying the toxin genes. It doesn't necessarily mean those bacteria are actively producing toxins and causing disease. You can get positive PCRs from horses that are just colonized, not sick. So PCR alone isn't enough to diagnose active CDI. It needs to be interpreted with the clinical picture and ideally toxin detection.
I see the distinction. Presence of the gene isn't the same as active toxin production.
Exactly. You can also culture the bacteria from feces, try to grow C. difficile, but again, finding the bacteria isn't enough because non-toxigenic strains exist in healthy horses. So culture should always be paired with toxin testing.
Makes sense?
The absolute gold standard reference test for toxin detection is called the cell culture cytotoxicity neutralization assay. It directly tests if fecal filtrate kills cells in culture and confirms it's C. diff toxin. But it's slow, expensive, needs specialized labs, so it's not practical for routine rapid diagnosis.
Okay, so ELISA is the main rapid toxin test.
Usually, yes. And vets often run other fecal tests concurrently, like looking at fecal cells under a microscope, cytology, doing a gram stain, culturing for salmonella, maybe PCR for equine coronavirus, just to rule out other common causes of diarrhea.
What about imaging? Can ultrasound help?
Abdominal ultrasound can be very useful. It might show things like diffuse thickening and edema swelling of the wall of the large colon. You might see excess fluid in the abdominal cavity or abnormal gut motility. A rectal exam, if safe to perform, might reveal thickened, edematous, large colon walls, or just find lots of watery, foul-smelling fecal material. And as we mentioned, vets are always keeping those differential diagnoses in mind. Salmonellosis, Potomac horse fever, even colitis caused by an SII toxicity or parasites.
It's definitely a complex diagnostic process. So once C. diff is confirmed, it sounds like treatment needs to be immediate and pretty aggressive. What does that road to recovery look like?
It absolutely does. Treatment is primarily supportive and, yes, often requires intensive care because the colitis and the systemic effects can be so severe. It's definitely a multi-pronged attack. The very first steps, if the horse is on any antibiotics that might have precipitated the issue, you stop those immediately, if it's safe to do so from the perspective of why they were started.
Right, stop the potential trigger.
Then, aggressive intravenous fluids. This is non-negotiable. We're talking huge volumes sometimes, liters and liters, to correct the severe dehydration, fix the electrolyte imbalances, low sodium, potassium chloride, and address the metabolic acidosis. The goal is to restore circulation, support organ perfusion, and combat shock. We tailor the electrolyte supplements based on repeated blood work. In really severe shock, sometimes we even use hypertonic saline initially for a rapid volume boost.
So fluids are foundational. What about hitting the C. diff bacteria directly?
Yes, specific antimicrobial therapy targeting C. difficile is usually started. The mainstay, the first-line choice, is metronidazole.
Metronidazole, why that one?
It's effective against anaerobic bacteria like C. diff, and it concentrates well in the colon, right where the problem is. It can be given orally, or if the horse isn't eating or has gut absorption issues, intravenously.
Okay. Are there other options if metronidazole isn't working?
Oral vancomycin is an option, but it's generally reserved for cases that aren't responding to metronidazole, what we call refractory cases. It's effective, but it's significantly more expensive, and there are concerns about promoting vancomycin resistance, which is a big issue in human medicine.
Right, resistance is a worry.
There's also a newer drug, fidaxomicin. It's a macrolide that works very well in humans with C. diff, but its use in horses is really limited right now, mainly due to cost. It's very expensive.
So metronidazole is the workhorse. How long do they stay on it?
Typically, treatment lasts for about 7 to 14 days, maybe longer, really depending on how the horse responds clinically. You monitor the diarrhea, their attitude, appetite.
And what about helping the gut itself heal from all that damage?
Good question. Gastrointestinal support is key. We often use gastroprotectants like omeprazole or ranitidine. These help prevent or treat gastric ulcers, which can develop secondary to the stress of illness or sometimes from NSAI use. Sucralfate is another helpful one. It acts like a bandage, coating ulcerated areas in the intestinal lining, offering some protection.
Like a protective layer.
Exactly. And then there are adsorbent agents, things like bismuth subsalicylate. Pepto-Bismol is the common brand or products containing smectite clay, like Biosponge or Guy smectite. The idea is that these can help bind up some of the C. diff toxins in the gut and maybe help firm up the feces a bit.
Finding the toxins, right.
Yeah.
And what about tackling those systemic effects, the toxemia you mentioned?
Yes, combating the systemic inflammation and endotoxemia is critical. NSAIDs, non-steroidal anti-inflammatories like flunixin, miglumin, banamine, are used routinely to reduce inflammation, control pain, and help with fever.
But carefully.
Very carefully, especially if the horse is dehydrated or showing signs of kidney compromise. And there's always a slight concern about NSAIDs potentially worsening a specific type of colitis called right dorsal colitis, although the benefits usually outweigh the risks in cases of severe endotoxemia.
Okay.
In very severe cases with signs of endotoxic shock, we might use polymyxin B. It's an antibiotic, but used at a specific dose, it binds to circulating endotoxin, neutralizing it.
Neutralizing the endotoxin.
Yes, and plasma transfusions can be vital. If the horse has lost a huge amount of protein, causing that severe hypoproteinemia and edema, giving plasma provides albumin and other essential proteins. It also provides clotting factors if there are concerns about DIC, disseminated intravascular coagulation, that dangerous clotting cascade.
Plasma for protein and clotting factors. Got it. Nutrition must be so important once they start feeling better.
Absolutely critical for recovery. Once the horse shows interest in eating, the goal is small, frequent meals of highly digestible, gentle feeds. Good quality grass hay is best. So hay pellets, complete senior feeds can also be good options.
Easy on the gut.
Exactly. You want to avoid rich grain concentrates initially, as they can be harder to digest and potentially worsen diarrhea. If the horse just won't eat for a prolonged period, anorexia, then we have to consider other routes. Enteral feeding, basically liquid nutrition through a nasogastric tube, might be necessary. Or in extreme cases, parenteral nutrition providing calories and nutrients intravenously, bypassing the gut completely.
That sounds intensive. What about the gut bacteria themselves? We talked about the disruption. Can probiotics help rebuild that? Or anything else?
That's a really active area of interest. The role of probiotics or prebiotics. Well, the direct evidence for treating active CDI is still a bit debated, honestly. Some vets use them, hoping to help restore a healthier balance.
So maybe helpful, maybe not.
The jury's still out on standard probiotics for acute treatment. But there's something else that can be remarkably effective, especially in difficult or recurring cases: fecal transformation.
Fecal transformation.
No,
That
don't
sounds interesting.
It does, doesn't it? But it makes perfect sense biologically. It's the transfer of fecal material, carefully processed, of course, from a healthy donor horse into the affected horse, usually via a nasogastric tube.
So literally giving them healthy gut bugs.
Precisely. The aim is to repopulate the sick horse's gut with a complete, balanced community of beneficial bacteria, essentially restoring the normal ecosystem. It can be incredibly effective for refractory C. diff colitis or other severe gut dysbiosis cases where antibiotics alone aren't enough.
Wow, that's quite an approach. You also mentioned laminitis prevention earlier as being vital. How is that managed?
Preventing laminitis is absolutely crucial because it can be a life-ending complication even if the colitis improves. The #1 strategy during the acute phase, when endotoxemia risk is high, is cryotherapy.
Icing the feet.
Continuous cryotherapy. Keeping the feet and lower limbs submerged in ice water, or using specialized ice boots almost constantly for the first few days. This helps reduce inflammation and blood flow carrying inflammatory mediators to the laminae in the hoof.
Constant icing. Okay.
Alongside that, deep, soft bedding is important. Supportive shoeing or hoof pads might be used. Anti-inflammatory doses of NSAIDs help. Sometimes vasodilators like acepromazine are used cautiously to try and improve blood flow within the hoof. It's a multifaceted prevention strategy.
And finally, biosecurity must be huge given those hardy spores.
Absolutely non-negotiable. Horses with suspected or confirmed C. diff must be isolated immediately. It's highly contagious via spore shedding in feces. Strict hygiene protocols are essential. This means dedicated personnel caring for the horse if possible, or at least changing clothes and boots. Separate equipment buckets, forks, thermometers, foot baths with an effective disinfectant outside the stall, and rigorous hand washing with soap and water. Alcohol-based hand sanitizers do not kill C. diff spores, so actual washing is critical.
Soap and water, not just sanitizer. Good point.
Very important point. And after the horse recovers and leaves isolation, the stall and any equipment used need thorough cleaning and disinfection with a sporicidal disinfectant, something that kills spores. Dilute bleach solution is often recommended and effective.
That's a lot of effort, but clearly necessary. So after all this intensive care, the fluids, the meds, the icing, what is the outlook? What's the prognosis for a horse that gets C. diff?
It really varies quite dramatically. It depends heavily on how severe the disease is, how quickly treatment is started, the horse's age and overall health, and whether complications develop. Milder cases, maybe just some diarrhea after antibiotics, they might resolve with just supportive care, stopping the antibiotic, maybe some adsorbents. But severe cases, the ones with profuse diarrhea, severe dehydration, toxemia, colic, those carry a much more guarded to poor prognosis.
What kind of survival rates are we talking about?
In studies based out of referral hospitals, where they obviously see the sickest horses, mortality rates reported can range anywhere from, say, 10% up to 40%, sometimes even higher in specific outbreaks. The overall rate across all cases is probably lower than that, but it's still significant.
So a substantial risk of not making it.
Yes. Death can result directly from the gastrointestinal disease, the dehydration, electrolyte loss, protein loss, or it can be due to the complications uncontrolled endotoxemia leading to multi-organ failure or severe untreatable laminitis. Often, euthanasia is elected due to the poor prognosis, the cost of continued intensive care, or the development of severe laminitis.
What about foals? You said they're susceptible but respond well.
Foals are definitely susceptible, but the good news is if CDI is caught early and treated aggressively, they can actually respond quite well. Their systems seem perhaps a bit more resilient in some ways, or maybe the disease pattern is different enough, but rapid intervention is key for them.
Is recurrence a problem? Can a horse get it again after recovering?
Yes, recurrence can definitely happen, especially if those predisposing factors haven't resolved. Maybe they need to go back on antibiotics for another issue, or if the initial antibiotic course targeting C. diff wasn't long enough. And even horses that recover fully might have a prolonged recovery period. Some might be prone to chronic low-grade diarrhea or just generally have more sensitive digestive systems afterwards. It really underscores why early diagnosis, really aggressive supportive care, and using the right targeted antibiotics are so critical to improve their chances.
So, given all this, what's the absolute key message for prevention? How do we try and avoid C. diff in the first place?
The number one strategy, the cornerstone of prevention, is the judicious use of antibiotics.
Using them wisely.
Exactly. Only using antibiotics when truly necessary, choosing the narrowest spectrum antibiotic that will be effective, using the appropriate dose and duration, anything we can do to minimize unnecessary disruption of that normal, healthy gut microflora is going to reduce the risk of C. diff getting a foothold.
That makes perfect sense. Protect the good bugs.
That's the goal. Less disruption means a healthier gut, means less opportunity for C. diff to cause trouble.
Well, this has been an incredibly thorough deep dive into Clostridium difficile in horses. It's really striking just how complex and potentially severe this infection is. And understanding that whole interplay, antibiotics, gut health, the environment, it really seems crucial for getting a handle on it. We really hope this detailed look helps you, whether you own horses, work in animal health, or are just curious, to feel more informed and maybe ask better questions and appreciate the steps involved in managing this.
I agree. And, thinking about how incredibly resilient these C. diff spores are and how much more we're learning every day about the equine gut microbiome, It really makes you think, doesn't it? What sort of breakthroughs in diagnostics, maybe faster toxin tests, or even more sophisticated personalized microbiota therapies like advanced fecal transplants or targeted probiotics, what might be just around the corner to help us better fight this really persistent and challenging infection in horses? The potential for progress feels quite exciting.
That's a fascinating thought to end on. Thank you for joining us for this deep dive.